Dr. Dasarath from Ayush Hospitals, Vijayawada. Today I'll be talking about the latest updates in the hypertension. I just want to tell you, according to WHO, nearly 63% of the total deaths in India were due to non-communicable disease. Usually, non-communicable disease are non-infectious, of which 27% are attributed to cardiovascular disease, which affects 45% of the people in the age group of 40 to 69 years of age group. Raised blood pressure, that is hypertension, is one of the most important risk factor for CVD. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. Coming to India, in India, the prevalence has gone up over 30 years to 38% in men and 32% in women, from 29% and 28% respectively. Despite that, nearly half of the people with hypertension were unaware of the condition. Additionally, over 62% of the men and more than 53% of the women are living with hypertension without getting any treatment. That's so pity that most of them are remaining untreated. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. And I'll just share few of the recent updates. And the International Society of Hypertension has released the ISH 2020 Global Hypertension Practice Guidelines. The inclusion of optimal and essential treatment paradigms attempt to address the issue that in resource poor settings, that is like India, where the resources are poor. Optimal care refers to evidence based standard of care, and whereas essential standards refer to minimum standards of care to allow specification of essential standards of care for low resource settings. The ACC-AHA has released a scientific statement in 2021 offering a new guidance for the management of stage 1 hypertension among low ASCVD. Like stage 1 hypertension means the patient who are in the blood pressure range of systolic 130 to 139 and diastolic 80 to 89. And the low ASCVD risk based on the parameters like our blood pressure, cholesterol levels, and sugar levels. All the population have been. This is basically a risk calculator. Based on this, all the population had been classified into low risk, intermediate risk, and high risk. And now we are talking about the low ASCVD risk population. Among the low ASCVD risk population with stage 1 hypertension, the management starts with non-pharmacological treatment, that is improving the lifestyle, like incorporating healthy diet in your lifestyle with the low salt and more vegetables, green leafy vegetables, and 20 to 25 minutes of exercise, moderate exercise for 5 days in a week, and other practices like yoga and all. These can be tried for 3 to 6 months, and one should consider starting pharmacological therapy, that is the medications for hypertension, if the blood pressure is not controlled within 3 to 6 months of the following non-pharmacological therapy. Other update is the acute respiratory distress syndrome, ARDS. It is potentially seen in many conditions, and now and the COVID-19 being the one of the recent popular disease, recent pandemic. Recent study which appears in the Journal of American College of Cardiology reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. There are certain targets that are set for the people for the lowering blood pressure among the elderly people. Previously, target among the elderly people more than 70 years was 130 by 80, and recent studies showed that lowering systolic blood pressure targets down to 110 to less than 130 mmHg range substantially reduced cardiovascular adverse events in the STEP randomized control trial, affirming the print findings from for an older Chinese population. Among some of the 8,500 population ages from 60 to 80 in China, the intensive target trimmed 26% of the composite CV risk. Findings from Norway, second major trial supporting the lower targets could unite the guidelines, which even among the US Professional Society range from threshold 130 to 150. Taking the concluding points among this, targeting a lower systolic BP 110 rather than 130 decreases the cardiovascular events. With regard to the prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European guidelines on the management of arterial hypertension recommend the diagnosis of hypertension should not be dependent on the office blood pressure measurements, but also an out of office measurement such as ambulatory BP. Ambulatory BP is nothing but a device called ambulatory BP monitor will be attached to the patient, and he'll be allowed to do his daily routines, and the BP will be measured in by the machine by in certain intervals, and all the recordings were analyzed, and based on the treatment is being trimmed, and 24-hour and nighttime BP measurements were associated with great risk of mortality and composite of CV outcome. Thus, they may be considered as the most relevant measurements for estimating CV risk. For every 20 mm in systolic and 10 mm in diastolic increment of BP measured at night, the risk of mortality increased by 23% and risk of cardiovascular events increased by 36%, which is quite a huge number. Most patients with hypertension require lifelong medical therapy to achieve optimal BP control. The 2018 European guidelines equally recommend five classes of antihypertensive drugs. Considering high non-adherence treatment, the importance of combination treatment is particularly highlighted to improve the adherence to the therapy and BP control. This will be more useful in countries like India where the resources are really poor. Therefore, the 2018 European guidelines recommend, especially the context of lower BP targets, to start antihypertensives with initial dual fixed combination of AC or ARB in along with the calcium channel blockers and diuretic. Since early July 2018, products containing volacetin have been recalled worldwide. The reason is the detection of a known carcinogen, namely N-nitrodimethylamine (NDMA), which can be found in candesartan, irbesartan, losartan, olmesartan, valsartan. The NDMA has been classified by the WHO International Agency for Research on Cancer to be carcinogenic in humans. If 1 lakh patients would have received NDMA contaminated valsartan from Xinjiang Pouhai every day for 6 years in the highest dose, it could result in 22 additional liver cancers over lifetime of these patients. The presence of NDMA in these drugs would lead to 8 additional cancer cases in 1 lakh patients if they had taken highest doses daily over 4 years. Valsartan call accompanied by significant increase in the rate of emergency department visits of more than 6% have been observed. The HYGEA study represents the largest study that tested the nighttime antihypertensive treatment. In this trial, chronotherapy was associated with significant reduction in endpoints, including death. The HYGEA chronotherapy trial tested whether the nighttime therapy in comparison to usual upon awakening hypertension therapy exerts a favorable CV risk reduction. The largest study included a total of 19,084 patients, hypertensive patients, during an average follow-up of 6.3 years. 1,752 participants experienced primary CV outcomes. An ambulatory BP measurement was performed for 48 hours to collect the data on how BP differed during sleep. The relative reduction of for CV events was significantly improved for nighttime treatment when compared to the awakening treatment. So these are few of the recent updates in the field of hypertension. The main emphasis of this recording of this talk is that I want to mainly highlight that most of the more than 60% of the men with hypertension and 50% of the women with hypertension are not on regular treatment for hypertension. Since the hypertension is one of the major risk factor for the cardiovascular disease, which is one of the most common form of non-communicable disease, it's better to start pharmacotherapy. And in this low resource country like India, we should try initially non-pharmacological treatments, and then if not controlled within 3 to 6 months, we should start on pharmacotherapy, and we should more focus on combination therapy so that the adherence will to the patient will be increased. Thank you.